Good morning, ladies and gentlemen. I'm Dr. Sini, your MC for today. Welcome to the 10th National Myeloma Forum. National University Cancer Institute Singapore, Singapore General Hospital, and Tan Tock Seng Hospital have jointly organized today's session to share with you more about multiple myeloma. We would also like to thank Amgen Biotechnology Singapore and Takeda Pharmaceuticals Asia Pacific for sponsoring this event. Due to this year's COVID-19 situation, we are unable to hold physical forums due to multiple safety and safe distancing issues. However, we are glad to bring you a series of interesting information for multiple myeloma via a virtual forum. We would like to highlight some pointers. First, your microphone has been muted by default. Please type your questions inside the Q&A box, and our specialists will answer them live during the Q&A section. At the end of the webinar, you will be directed to the feedback form survey. We will greatly appreciate if you can take a couple of minutes to complete the form. Before we begin the program, please sit back and relax as we share with you our journey in the past 10 years in a 2 minutes video montage. Thank you for the wonderful video montage. Next, let's invite Professor Cheng Lijun, Director of the National University Cancer Institute Singapore, for an opening speech for this event.
Good morning, everyone. I hope everyone is keeping well in this COVID times. I would really like to welcome everyone who has joined us to this, our 10th annual Multiple Myeloma Patient Forum, and spending your Saturday morning with us. Today with us, we have some old friends. As we said, this is the 10th year. So Dr. Daryl Tan and myself have been involved in this symposium for all the past 10 years. Some of our colleagues in the early years have moved on to other institutions, one of them overseas to Canada. But we do have newer people joining and become part of this very close-knit community. So Dr. Lee, Dr. Chen, Dr. Mauli will also be sharing important aspects of myeloma management with you later today. As I said, this is a landmark year. This is the 10th year we've been doing this. We started this forum in 2011 because we wanted to create a platform where patients from across Singapore, treated at different institutions, as well as the experts and the myeloma doctors, to come together to do sharing about their experience, to help each other, as well as a platform for learning about the latest information about how to manage some common problems that they experience as they are undergoing treatment. And really, this platform has gone from strength to strength. Actually, many of the patients and caregivers have become friends over the years. They have been able to start some activities on their own, sometimes social, sometimes sharing of experience. And, you know, in a way, it has taken a life of its own, right? Which is also something extremely gratifying for us to see, because when we started, we did not actually fully expect this to happen. And really, when we started in 2011, we never expect the world to be what it is today, right? Nobody expected at that time that the UK will leave the EU. Nobody expected someone like Trump would be president of the United States and that people would actually elect him. We never expected something like COVID-19 will happen. Despite our SARS experience, COVID-19 is a completely different beast here. Nobody expected that the country will be locked down, that we will not be able to travel, right? So tremendous change this last 10 years. And similarly for myeloma, this last 10 years has been times of tremendous change as well. And you will hear a bit about this in the series of talks later. But I'm glad to say that the changes in myeloma are almost all in the positive direction, right? So unlike some of the troubles that we've seen around the world, myeloma is progressing in the right direction, and we're doing better and better compared to before. Usually, our patient forum will be a physical meeting. We enjoy these physical meetings because it's a once in a year for us to get together, to catch up with familiar faces and so on. It's a bit like, our Chinese New Year get together, right? So unfortunately, this year, due to this COVID situation, we are unable to see each other face to face and catch up. So I'm a bit sad about that, but I always look at the silver lining, and even this situation provide us with new opportunities, right? So by using Zoom as a platform, today we have about 300 registrants for this meeting. This is larger than it has ever been before when it's a physical meeting. So it allows us to reach out to new patients and caregivers, to the public who is interested to learn more about myeloma, but also for us to reach out to foreign patients and foreign colleagues who may be interested to find out more, right? So I think I would just want to end by saying that even for the COVID for Singapore, I think we can see the light at the end of the tunnel. We now have about 10 days without any community-acquired cases. Vaccines are coming along quickly. There are two good ones that seems to be getting approval soon in the US, and others are coming along. So we're really seeing the light at the end of the tunnel. And I hope that after today's meeting, you would learn that for myeloma patients, it's the same. We are seeing more and more light at the end of the tunnel because our treatment are getting better. Our ability to support our patients are getting better. The survival is getting longer. The cure rates are getting higher. So I think this is a very positive time. And in fact, the future will be even rosier for myeloma patients. So without much further ado, I hand back to the moderator, to Sini, to kick us off on today's seminar or webinar. Thank you very much.
Thank you, Professor Chung. Now, let's welcome our first speaker of the day. Dr. Lilian King is a senior consultant from the Department of Hematology at the Tan Tock Seng Hospital. Dr. Lee will share more on infection in multiple myeloma. So now we are going to move on to our second speaker. Dr. Chen Yin Xin is a consultant from the Department of Hematology at the Singapore General Hospital. Dr. Chen will talk about the role of stem cell transplantation and supportive care in multiple myeloma. If you have any questions, you can please type it in the Q&A box and we'll answer them later.
Thank you, Sini, for the introduction. So again, good morning one and all, and thank you for joining us on this 10th National Myeloma Forum. Today I'll be sharing on the role of stem cell transplantation and supportive care in myeloma. And it's my pleasure to share with you some insights that we have gained over the years in this topic. So briefly, I will cover the disease and treatment background of myeloma that will lead into the role of autologous stem cell transplant as a treatment avenue for myeloma, as well as the future of stem cell transplant in myeloma. And lastly, I will cover a little bit about the supportive care in myeloma. So just briefly, as we know, some of us may know, myeloma is a B-cell neoplasm that arises from clonal proliferation of terminally differentiated plasma cells. So the bone marrow produces stem cells, which differentiates into different cells, blood cells in the body, chiefly the red blood cells which carry oxygen, white blood cells which fight against infections, and also platelets which help with clotting. The myeloma stems from the different abnormal plasma cells which come from the lymphoid cell lines. In stem cell transplant, the stem cells that we use will be able to proliferate into the different cell lines, contributing to the recovery of all these different blood cells. So in a normal situations, we need many different plasma cells to help us have a healthy immune repertoire as they are chiefly in charge of producing antibodies, and different types of antibodies are responsible for fighting different kinds of infections. When cancer occurs, such as in myeloma, there's only one clone of plasma cells which can grow and proliferate in that sense, and it only produces specific kinds of antibodies. Because of this, myeloma patients suffer from immunofluorescence, as covered quite thoroughly by Dr. Lee earlier, and they experience many different kinds of infections. Also, because of the increased plasma cells, it leads to many different problems, such as increased proliferation in the bone marrow. As such, the normal blood cells, such as the white blood cells, the platelets, and the red blood cells counts are low in that sense, and contributing to anemia, bleeding problems, infection problems. The huge amount of antibodies secreted by the abnormal plasma cells can also jam up the kidneys, leading to kidney failure, and also sometimes thickened blood. Myeloma cells also secrete some abnormal cytokines, which lead to bone destruction. And many a times we see patients who first present with bone fractures that bring them in and subsequently get diagnosed with myeloma. So as you all may know, we still call myeloma incurable, but very much treatable. And it's because in the pathogenesis of myeloma, there are sometimes many different clones. As such, after first treatment of myeloma, they can enter into remission, but subsequently, after some time, the disease inevitably tends to come back again, as such what we call relapses, and comes a point of time where the disease cannot be controlled adequately and the patient succumbs to it. What we hope to see in a lot of our patients, and what we hope that treatment brings about, is that after diagnosis of the patient, we give very good first-line treatment, bring about long-term remissions, what we call very deep remissions, such as having very minimal residual disease, and have no relapses in the near or long-term future. And they also suffer from no treatment-related toxicities. And actually, as treatment advances, we are getting nearer and nearer to this kind of treatment outcomes for our patients. So as such, there are different kinds of studies that have grown to show that the deeper we can get the patient into response for myeloma in the upfront treatment, the longer we can keep them in remission. So this is a chart showing what we call MRD negativity rates. So you see, when a patient starts off with a lot of disease load, as we treat them, the lower the disease load we can get them into, which is what we call at this point of time minimal residual disease negativity, or MRD negative, the longer the time it takes for the disease to come back, and which means the longer the time we can keep the patient in remission. And this forms the basis of stem cell transplant, because we know that we want to try to get the patient into a deeper response, and show, as shown in some of these curves, that the blue ones showing what we call MRD negative rates, and they have better survival outcomes than the patients who are not MRD negative, as shown in the red curve. So if we could get them into what we call MRD negative, the time to progression, which means that the time they remain in remission, is longer. For example, in this, if we can get them to MRD negative by disease criteria, the average time for progression is about 5 years, as opposed to about 2 years for patients who are not MRD negative. So the concept of treatment is as such. In a transplant-eligible patient, we have different blocks of treatments. So usually we start off with a combination induction therapy that incorporates a proteasome inhibitor, such as bortezomib, or B, in this short form, B for Velcade, or combined with an immunomodulator or an alkylator, such as lenalidomide, cyclophosphamide, and a steroid. So this block forms the induction treatment. Thereafter, we will want to lead the patient into what we call high-dose chemotherapy with autologous stem cell transplant, and then bring them to what we call consolidation and maintenance. In transplant-ineligible patients, because we cannot put all patients to transplant, we still rely heavily on the different blocks of treatment, such as combination, frontline therapy, as well as maintenance. So today, my talk will focus mainly on the rationale why we deliver high-dose chemotherapy and autologous stem cell transplant in the myeloma patient. So firstly, as you know, often after induction treatment, where we start off with a high disease load, after induction treatment, there can be residual plasma cells or abnormal cancerous cells left in the bone marrow. This is a mix upon the normal cells in the bone marrow, such as the normal white blood cells, the normal lymphocytes, the normal red blood cells, platelets, etc. So often we want to target these residual plasma cells. It is not always possible to deliver treatment that can just get rid of these abnormal cancerous cells without affecting the good cell lines. So what we do to actually kill off all these bad cells is to deliver a very high dose chemotherapy treatment to try and eradicate the abnormal cells. But at the same time, these high-dose treatments can also kill off the normal cell lineages like the normal white cells, red cells, platelets, etc. So we have to find a way to actually replenish all these normal cells to help the patient recover their function, their normal blood function. And this is where transplant comes in. So what autologous transplant does is to enable us to deliver high-dose chemotherapy, and the stem cells serves as a way to rescue the bone marrow from bone marrow failure. So what happens is that we first, after treating the patient to a good response, we collect out the stem cells, the stem cells through a harvesting mechanism such as peripheral blood stem cell harvesting, and store these stem cells. Subsequently, we deliver the high-dose chemotherapy to ablate the bone marrow and get rid of the whatever residual cancerous cells there is in the bone marrow. These stem cells are then reinfused post-delivery of this high-dose chemotherapy, and then they will regenerate and proliferate to sort of replenish the good cell lines, such as the white blood cells, red blood cells, and help the patient with recovery. So mainly the whole concept of autologous stem cell transplant in myeloma is to deliver high-dose chemotherapy, and the regenerating stem cells proliferate into hematopoietic stem cells of different lineages. I just want to briefly mention the kind of stem cell that we do in myeloma patient, which is autologous stem cell transplant. It's different from the allogenic stem cell transplant that we sometimes hear about in news, in literature, etc. So in autologous stem cell transplant, the stem cells are actually harvested from the treated patients themselves. These are stored and then reinfused after high-dose chemotherapy. Allogenic stem cell transplant are somewhat different, where there is a patient and there is a donor. So the stem cells are actually harvested from a healthy donor, and this can be the siblings, unrelated matched donors, or from cord blood. These stem cells are then reinfused to the patient after they undergo high-dose chemotherapy. So what's the difference, you may ask? So autologous stem cell transplant, the main role is to actually replenish the absent normal cells in the patient. Whereas for allogenic stem cell transplant, the stem cells from the donor can replenish the absent normal lineages, but they also have another purpose in that some of the specific cells called T lymphocytes actually serve to attack the disease cells for disease controls. But these killer cells or T cells can also have a disadvantage, which is that they can cause self-attack, or they can attack the patient's own cells, leading to complications such as graft versus host disease. In myeloma, we can do autologous stem cell transplant because remember this slide that I showed earlier, the disease cells are plasma cells, and hence collecting the stem cells, these stem cells tend not to be affected by the disease mutations in that sense, and they serve to replenish the good cells. However, in some diseases, such as acute leukemias, where the stem cells are affected, autologous stem cell transplant are not so effective in that sense, and they might cause further problems. So there are different indications for both autologous and allogenic stem cell transplant. Autologous stem cell transplants are more so used for myelomas, lymphomas, whereas allogenic transplants can be used for leukemias, lymphomas. The autologous stem cell transplant is mainly for stem cell rescue and has no disadvantage of causing graft versus host disease, as compared to allogenic stem cell transplants, whereby the patients can be affected by graft versus host disease. We need to find a donor. There can be issues with a lack of donor. We do not really do allogenic stem cell transplants in myeloma because of the high risk, but in certain situations, very, very specific situations where the patients have past relapses, this might be considered in a very well-selected population of myeloma patients. So just to briefly summarize the process of autologous stem cell transplant, at diagnosis, the patient would most of the time receive about 3 to 4 cycles of combination induction treatment. We get them into partial response of better, and there's still some residual plus cancer cells, which we want to try and attack. We then subject the patient to what we call mobilization chemotherapy, or the process of trying to harvest the stem cells. So this is usually treatments such as vinorelbine, cyclophosphamide, and at the same time, we give the patients some stem cell mobilizer, such as GCSF, and at times with combination with a drug called plerixafor. The stem cells are harvested from the patient and stored. The patient then comes in again for the autologous stem cell transplant process, whereby the high-dose treatment therapy or conditioning chemotherapy, such as melphalan, is delivered. This wipes out the patient's bone marrow, including as much of the cancerous cells as possible. The stem cells are then reinfused to the patient, and these stem cells are allowed to proliferate, to regenerate the healthy cells in the patient. So why do we do transplant in myeloma patient? It has been shown that it is an effective treatment, And as compared to, in some trials, as compared to standard therapy, which is without transplant in this case, transplant offers a longer time to remission-free survival. So in this graph, we see that the average time for a patient to progress when transplant is added on into their treatment regimen is about almost like 3 years, whereas if they don't undergo transplant, it's probably closer to 1 to 2 years. So it also increases overall survival, that means extends life by about a year. However, we do know that transplant is not curable in that sense, and we do not stop treatment for myeloma patients after transplant because there can still be residual plasma cells that cannot be detected by our current technology. So in that sense, the thereafter post-transplant, such as consolidation and maintenance, is still important. And across many different trials, such as the newer ones, which incorporates daratumumab into the backbone agents, it shows that such treatments, such as after consolidation, giving more therapy and maintenance actually deepens response. And as shown earlier, the deepening of responses contributes to better survival outcomes. So transplant is not the be-all and all in myeloma treatment. The consolidation maintenance part is still important in our patient. However, we still can say that transplant offers a very good effective treatment in this current day age. So why do we still recommend stem cell transplant? If you look at a typical clinical course of a myeloma patient, after combination induction therapy, without any subsequent treatment, the disease tends to relapse after some years. And with each relapse, the times that they spend into remission is generally shorter. The disease is more resistant and gets harder and harder to treat. With transplant, it prolongs the time the patient can be in remission, delaying the time whereby the disease may relapse again, and thereby offering the patient a better survival outcomes. This can be further improved by adding on some maintenance treatment after transplant per se, prolonging the time in remission even more. By maintenance treatment, we generally mean usually 1 or 2 myeloma drugs that are more convenient, less side effect, that keep the patients at low-level disease levels for longer periods of time. Oftentimes, we also see some patients who do very well on transplant, and they can last many years without the disease relapsing. And we do have certain patients who, after a single transplant, can remain in disease-free states for more than 10, 20 years. And these are the patients that we often want our patients to be, and to offer them the best chance at survival and defeating the myeloma disease. So also, in large number of trials that are done in the US across different eras, we see that even in the current states where you look at the purple, orange, and green line, patients who undergo transplant, there are actually about maybe 30% of the patients who are progression-free at about 10 years. And if we take 10 years as a good time of calling a patient sort of functionally cured, even though we don't say that myeloma patients are curable, 10 years to be progression-free is a very good period. And if we can get a third of our patients with a transplant into this form of long-term remissions, then transplant still, at this point, remains a very effective therapy. So about a third of patients do have good long-term outcomes post-transplant. Then you ask again, what are the alternatives then if we don't do a transplant because they have their complications, as I will mention later? I think sometimes when you all read studies in the US, some of them offer what they call late transplant, which is transplant at relapses, whereby you treat the patients again with combination therapy. Only at the relapse do you offer the transplant. The issue about this is that we are not sure whether the patient can successfully mobilize or we can successfully collect stem cells, because the more cycles you treat the patients with, the harder it is to successfully collect the stem cells. Also, at relapse, we are also unsure how the patient is. Sometimes they are less fit, they are older, the organ functions such as kidney functions, heart functions may not be as good, and hence they might not be eligible for a transplant. And in that case, the stem cell transplant cannot be done anymore, and the patient does not get such an effective treatment. So, and also the disease can be more refractory. And hence, what we do locally, we still opt for an early transplant, as it has been shown to have survival benefits. And we can be assured that at this point of time, the patient tends to be fitter, at a younger age, more likely to have successful stem cell harvesting. More and more so, many of us are asking the question of whether this is the future of myeloma treatment, since we have so many more effective agents coming on, is to treat the patients with much more effective treatment giving them many more cycles and get the disease into a very good response, such that they attain MRD negativity. And in this case, can a transplant be omitted in that sense? I think one of the studies that looked into this is this recent trial called the Forte trials, which used upfront carfilzomib, a newer generation of a proteasome inhibitor that is coming up into the market. So you can see arm B, which is the red block, as compared to arm C, which is the green block. They have the same induction agent, which is carfilzomib, lenalidomide, and dexamethasone. Thereafter, some of these patients undergo transplant, whereas other patients just continue to receive the combination chemotherapy. As compared to these two, which is the patients who had a transplant versus those who did not, the responses were quite similar. Here you can see the blue one representing the patients who are in stringent complete remission, which is a very good response in terms of myeloma patients, and they were quite similar. This is the same, also seen in what we call MRD negativity rates. It is similar in the patients who undergone transplant and those who just received chemotherapy. However, as these patients were followed up longer time, at about 1 year mark, the patients who actually undergo transplant, more of them actually remain in MRD negativity rate, which means that there is very little cancer cells that return in the patients who undergone transplant. Whereas you can see that the patients who just had received chemotherapy, more of them have the disease somewhat returning. That means conversion from MRD negative to MRD positive, as in they don't remain persistently MRD negative. So if you ask me whether this can be the future of myeloma treatment, I think not quite yet, because we need more long-term data. We are also not sure whether this added cost of treatment actually is more costly than the transplant itself. Also, because we give patients this many cycles, as opposed to a transplant, we cannot weigh out the different toxicities that the patient may experience, as increasing cycles may lead to cumulative accumulation of toxicities. And hence, at this point of time, this is still the approach we do for patients who are eligible for stem cell or transplant. What are the complications of stem cell transplant? So because we deliver high doses of chemotherapy, much of the complications can be related to chemotherapy itself, such as nausea, vomiting. Sore mouth can be quite an issue in many of our patients. Sometimes we might even need to give infusional nutrition, such as drips, or parenteral nutrition, such as different kinds of drips. They can experience quite severe diarrhea, and they will all have higher hair loss. The complication that we are very much concerned with are also related to the low blood counts. If you remember, the high doses of chemotherapy wipes out the bone marrow, and whilst waiting for the bone marrow to recover from the infused stem cells, they often spend about 1 to 2 weeks whereby they have very low counts. When the patients have very low counts, there is no effective immune system to defend against ongoing infections, and hence the infections can be severe, and sometimes they might require ICU stays to help support them during this critical period. And of course, we do lose some patients, although a very small number of less than 5%, because of these severe infections. Because of the low blood counts, such as hemoglobin levels and platelets levels, they can have issues with bleeding as well as anemia and might need transfusions. The long-term side effects of the transplant itself, the patients can also have infertility issues. So in the very young patients, we do counsel them and do have some processes whereby we do sperm cell collection or oocyte collection before the transplant. There can be organ toxicities such as kidneys, toxicities to the kidneys, liver, or heart, as well as development of secondary cancers such as long-term development of bone marrow cancers. Just a few last part about immune and cell therapy, because I think this is an up and coming treatment, and some of you might have read about this immune and cell therapy and have questions about it. So what is immunotherapy? What is cell therapy? And is it the same as a stem cell transplant? Is some of the questions you might ask. So I think if we took that simplistically, immunotherapy is just trying to harness our own immune system to battle cancer. And we know that our immune system has the ability to do so. It's just that in cancer patients, sometimes this is more suppressed in that sense, and we are trying to boost it up such that it can regain the powers to battle the cancers. It can be broadly divided into drugs and also cell therapy. So in terms of drugs, there are already some drugs that we have been using in myeloma treatment all along, such as immunomodulators, including drugs like thalidomide, lenalidomide, and pomalidomide. So these drugs act upon other cells in the bloodstream, such as the T cells, to help them secrete some chemicals, such as cytokines, to help attack the cancerous cells. There are also other drugs that are developed more in recent years, targeted antibodies or monoclonal antibodies in that sense, such as daratumumab, which targets CD38, which I think some of you might be familiar with, and up-and-coming drugs such as belantamab, elotuzumab. So this target surface antigens, which means the cells, the cancerous cells expressing certain antibodies and try to kill them off. In terms of cell therapy, I think actually it has been ongoing for many years, and one of the kid on the block, the best known form of cell therapy is actually the allogenic stem cell transplant itself. If you might remember when I mentioned earlier, the allogenic transplant, there are certain cells called the cytotoxic T cells, which are killer cells. They attack the cancer cells and try to wipe them out. These are because these cells come from the donors. They recognize the cancer cells as being foreign and being enemies, so they attacked it. But at the same time, they can have problems with attacking the patient's normal cells and causing problems with intestines, skin, liver problems, etc. So if I were to extrapolate it, this is almost, you're doing an allogenic stem cell transplant. It's almost like using a nuclear bomb to wipe out the patient's cancer cells, but causing many problems. So it attacks both the enemies, but causes a lot of bystander effect. So what we want to is actually to do this. Can we find a sniper to kill out the enemy and leave the bystanders alone? And I think more so in recent years, people have talked about adoptive T-cell therapy. And one of the best examples is the use of CAR T-cell therapy or chimeric antigen receptor T-cell therapy. In this case, the patient's own T-cells, which are the killer cells, are extracted or harvested from the patients themselves. And then we do genetic engineering to equip them with ability to recognize and attack the cancer cells. So in this case, the T cells are engineered in a laboratory outside of the patient and then returned back to the patient. So as opposed to an allogenic transplant where we just take donor T cells and give it back to the patient, these are more tolerable to the patients as they are from the patients themselves. The patients do not reject these T cells. There are no problems such as graft versus host disease. So is this the future in myeloma treatment? I think one of the largest trials that have been done in terms of CAR T cells in the United States, the drug so far is called Idacel. Another name is a BB2121. As we know, CAR T cell treatment has been shown to be very effective in pediatric patients with acute lymphoblastic leukemia. And in about half of the patients, they can actually be cured. But we do not actually still see this at this point of time in myeloma patients. And as you can see from this curve, there is no plateau that we see in the myeloma patients, which means that most of the patients still relapse, although there are some patients who do well and have remission-free periods of close to 2 years. But on average, the patients still relapse within a year or so. And there are still complications associated with CAR T-cell therapy, such as when this treatment brings about cytokine release, and this can cause issues such as fever, heart issues, liver issues, renal issues, and also some confusion and all. So at this point of time now, possibly this is still not the answer to our question. There are many rapid developments in this arena, and we really hope to see this or other treatments bring more hope to our myeloma patients. So at this point of time now, autologous stem cell transplants still remains one of the main treatment in myeloma patients. And when a patient is transplant eligible, we always still talk to the patient and try to incorporate this as much as possible into the treatment of myeloma patients. Just a last slide on supportive care of myeloma patients. If you remember, the plasma cells in myeloma patients can cause bone marrow infiltrations, paraprotein, and so the antibodies can clog up the kidneys, and also the cytokines release can cause bone destruction. So supportive care is generally revolving around these issues that can develop in myeloma patients. So in terms of bone disease, we often advise patients for what we call anti-resorptive therapy, including such as bisphosphonates, denosumab. In patients who have fractures, early surgery or radiation therapy is also important to salvage any form of neurological recovery, as sometimes the lesions themselves can cause cord compression, leading to inability to walk, and addressing all these problems earlier can help them to recover their ability to walk. Also, because of low blood counts, they can have anemia. So most of the time we try and correct any reversible causes such as nutritional deficiencies that we have, and also administration of certain drugs such as erythropoietin. In terms of infections, I think Dr. Lee has covered in detail earlier, so I will skip that point. In terms of kidney impairment, oftentimes we might not be aware, but there are drugs that can actually potentiate kidney damage. And in myeloma patients, many of them do have bone pain, so they can be taking painkillers. And certain painkillers, such as NSAIDs or general term NSAIDs, can cause kidney damage. So it is important to be aware and try to avoid those medications when we are approaching a myeloma patient. Dialysis can be considered in some patients in the earlier stage when the disease load is very high to try and salvage kidney function. Also, because they can have blood clots or risk of causing clotting problems in patients who are at very high risk, such as those who have bone fractures and are unable to walk for some time. Blood thinners, such as injections of taxane, can be also used in the supportive care. And the patient are always advised to avoid sedentary lifestyle, try to be more active or do some brisk walking if they can. Mental health is also extremely important, and hence later on we will touch upon the availability of some support groups to provide this avenue of support. With that, I would just like to summarize some of my key points, which is that autologous stem cell transplant in myeloma provides for stem cell rescue after high-dose therapy. High-dose therapy, such as melphalan with the stem cell transplant, remains an effective way to achieve control of disease in myeloma. With regards to new developments such as novel agents, whether this can potentially replace transplant, as well as CAR T-cell therapy and its role in myeloma treatment, these need further data and optimization before we can say that it is a gold standard to be used in all myeloma patients. Supportive care is also effective in myeloma treatment and is key to effective myeloma treatment. It includes the management of bone-related complications and kidney impairment and infective complications. So with that, I end my talk. So the treatment of myeloma patients is always a whole village. Our patients and their caregivers always give us the inspiration to do better for our patients. And I also want to thank the very good transplant team I have at SGH, who have been very supportive. Also, we have a very collaborative team in Singapore across all institutions. Thank you.
Thank you, Dr. Chen. A gentle reminder, we'll have a Q&A segment later at the end of the webinar, so please feel free to type your questions in the Q&A box. Now, let us invite our third speaker. Professor Chong Wee-Joo is the Director of the National University Cancer Institute, Singapore. Professor Chong will share more insights on multiple myeloma in Singapore, progress in the last decade, and what the future holds.
Thank you very much, Sini. So it's a pleasure, as always, to have this opportunity to speak to our patients, the caregivers, and others who are interested in myeloma. I think many before and maybe even the speakers after me will talk a bit about this, but I think because for the first time, I think we'll have potentially people who have no knowledge about myeloma from the public. I think it's well worth stressing this again. So multiple myeloma is a type of blood cancer that arises from cells that normally live in our bone marrow called plasma cells, right? So in normal people, we do have plasma cells, and the plasma cells actually serve a very important function because these are the same cells that produces antibodies that help us fight infection. Right, but in this condition, something happened in one or two of these normal plasma cells that their genetic become abnormal. All right, so a mutation or some abnormalities happens in their genes, and this abnormality make this one or two plasma cells act abnormally, so that they start to grow in a very aggressive manner. They expand, and they are able to then take over or suppress the normal plasma cells. So, as Dr. Lee mentioned, one of the problem initially when patients present could be a poor immunity, because now their normal plasma cells that produces all these antibodies that help us fight infection are no longer effective. Whereas most of these plasma cells now is that one or two clone of abnormal plasma cells that produces only one type of the antibody protein, and this is what we call the monoclonal protein or the M protein, right? So you can see on this slide on the left-hand panel are these plasma cells. Normally, they will have a single nucleus with this cytoplasm, but in myeloma you have these abnormal ones, right, where you have two nucleus. So you see that this is not normal, and to produce this protein that you see on the right-hand panel, if you can see my arrow, that let me just get this the laser pointer here. You can see that this is the protein that we see in myeloma patient. Normal patients will not have so much down here, right? And also all in just one location. So this is the abnormal cells, and these are the proteins that they produce. And because of this, they produce a range of different abnormalities in the patient or problems in the patients. These proteins get secreted or excreted in the kidneys. And when you have a lot of the cells that produces a lot of the protein, then the kidneys could be blocked by these proteins. Whereas normally, our immunoglobulins as produced is at a base level. The kidneys knows how to handle them. But when you have a lot of these cells, because it's a cancer and producing a lot of protein, then the kidneys may get damaged, right? So the patients may get renal impairment. Because these cells live in the bone marrow, and when you grow, they start to suppress your normal blood-producing cells and so on. You may get into problem with low blood count, low white cell count, low platelet count, and so on. Because of the some of the factors that they secrete and how they interact with the other cells in the bone marrow, this may actually lead to a weakening of the bones, right? Where the bones are being resorbed with no new bones being formed. And so very typically in myeloma patients, they may get bone pain, they may get weaknesses in their bone that leads to easy fracture, right? And when you do an X-ray on these patients, you may see these holes, so-called the holes or the weak areas in the bones, right? And it's because of this interaction with the plasma cells and the proteins that they secrete, right? Because of that, and also partly because of the kidney problem, they may get high calcium level. And so sometimes if you read in the web and so on, you may come across this terminology of the crab symptoms, right? CRAB, like the crab that we eat. And that stands for, the high calcium, the C. The R stands for the renal problem. The A stands for the anemia. And then the B stands for the bone disease. So in general, patients may get 1, 2, 3, or, the ones who present maybe with severe disease may get all of these types of issues, but they don't always have to exist all together. And one of them may, most patients only have one of them, which is also why myeloma is a difficult diagnosis, because these problems, they don't come to the specialist straight away, right? If they have anemia, they may get a bit more tired easily, maybe a bit more breathless, they may go to their GP. Myeloma also tend to affect older people. So if you're older and you're just a bit more tired than your usual, again, people may not think that it's a very significant problem, right? People with kidney impairment, they may present to the GP or the kidney doctors, and if they don't think about myeloma, they may not check it because it's not the most common cause of renal impairment, right? Then the diagnosis may be delayed, right? Patients with hypercalcemia, high calcium, may present with like non-specific pain, discomfort, and so on. And again, so a lot of these symptoms are not very specific. Diagnosis may be a challenge, which is why I think we do a lot of road shows to our colleagues in the hospital. We do GP or polyclinic education sessions where we try to teach our colleagues actually as well, how to recognize and how to have a high level of suspicion for myeloma, and to do the appropriate investigation when that is the case, right? So these are the important clinical features and the reasons behind how myeloma patients present. But the more exciting part is really, as highlighted by some of my colleagues, is myeloma is also one of the cancer in the world that has the most tremendous progress in treatment over the last decade, right? And this is exemplified by this slide here, where you can see that for years, right, from the 1960s to the 1990s, that's about 3 decades, right? 30 years. The number of new treatment that there are for treating myeloma was very few, right? It's chemotherapy, melphalan, vincristine, erythromycin, doxycycline. These are all chemotherapy, the old-fashioned chemotherapy, and steroids, right? And then they use more of the chemotherapy for the transplant, right? So it's all around chemotherapy. But then starting from the 2000s, we really have seen a rapid progress in approval of new drugs. And the great thing is almost all of these drugs are non-chemotherapy drugs in the conventional way. They are what we call targeted therapy that has a specific action on either a molecule in the cell or on the immune system. And they are a completely different kind of approach to cancer treatment, right? And the rate of progression is rapid. You can see that I've summarized here 12 drugs approved since 2000, but 8 drugs approved in the last 10 years. So the rapidity of approval seems to be faster, right? In the first decade in the new millennium is 4 drugs. And then in the last decade, 8 drugs, right? And Dr. Chen has already highlighted in the future, there are more exciting things that target different molecules and uses the immune system, to help to tackle this cancer in the form of different types of immune therapy, like CAR T, like the bispecific T-cell engagers, like the antibody drug conjugates. And the interesting thing also is they target different proteins, right? Not the same protein. So we now will have a really huge armamentarium or weapons to treat myeloma patients going forward. And what is the impact of this, right? So what if we have a lot of good treatment? The impact really is that you can see on this graph as well, and that's not even including all the latest treatment, is that you can see that this red bar is progressively going higher and higher. And today, we're almost nearing 100% response rate when we treat a new case of myeloma patient, right? And we use a good combination such as this highlighted on these slides. And not just that, for certain combinations, the complete remission rate just with the induction treatment, we're getting about close to 40% for some of these. And when you add on the transplant, this can go up to 60, 70% potentially as well, right? So with today's treatment, we are getting response rate that is close to 100% with a complete remission rate close to 50%. And this is a tremendous improvement where you look at what it was like in the past, where you have less than 10%, about 5% of patients getting a complete remission. So it's almost like 5 times improvement in terms of that kind of outcome. And response is very important because they translate into better survival. The patients are surviving longer and longer. So this is just data from the National University Hospital, ANSYS. And you can see that in the first decade of the millennium, for the transplant eligible patients, about 9 years. No, about 9 years. And then in the more recent decades, about 10 years now. For the more older patients who are transplant ineligible, the outcomes is less because obviously of their age, the ability to give them treatment may be compromised by the toxicity that we achieve. Which is why what we learned and also highlighted by Dr. Lee in the first talk is that for the older patients, the important objective may be not to give them very strong and intensive treatment to try to get them into very deep response. But in older patients, sometimes less is more, right? So the important balance there is to make sure we adjust the doses so that it's tolerable to the patients. They can continue for treatment for long, rather than give them strong treatment that they cannot tolerate and we have to stop treatment early. It's important to play the long game. Sometimes with a lower dose, with a better combination, rather than many drugs, use less drugs and maintain them on treatment for a longer period of time. That is often better than trying to give very strong treatment that people cannot tolerate. This is for the older patients. For the young patients, I think the important thing is to give them the best treatment, the strongest treatment that we have up front, so that they can achieve the best outcome and maintain it for as long as possible. And you can see that we're doing very well all the time. Before the millennium, these patients are surviving for only about 5 years or less, right? And the transplant ineligible older patients are even less than that. So I think these are tremendous progress in terms of better outcomes because we have better drugs. And in fact, the question of cure often come up. We are a bit cautious in the myeloma community. We do not say that someone is cured because we, in the long term, the disease may well come back and may need treatment again. But actually, when we look at the data, there are patients that are surviving, not just surviving, but have a treatment and is in remission and do not have any progression for more than 10 years. And this number is in the order of 25 to 35%, depending on what studies you're looking at. So on average, about 20 to 30% of patients, myeloma today, potentially can have a disease-free period for more than 10 years. And these people, what Dr. Chen has said earlier, we're calling them functionally cured. We're a bit cautious because technically they may well have disease coming back later. We don't know yet. But I think, again, when we think about, are there a portion of myeloma patients potentially may not need or may not have a disease progression and may be cured? There potentially is about 20 to 30%. So this is also a tremendous improvement compared to the past where, this is not even something that we can consider. So we have great treatment that can produce this great outcome and, potentially increase the cure rates. What is the problem, right? I mean, this is all great, but, life is never a bed of roses. There are issues. And the issue is that it's no good to have all these good drugs, but we cannot give it to our patients, either because the drug is not available in Singapore or because the treatment is so expensive that our patients cannot get access. So treatment costs. Or the way that it is given is inconvenient to the patient. And because we are talking about long-term treatment as the best approach for our patients, then there may be sometimes fatigue in receiving treatment, compliance issue may come in, and so on. So really, our approach in the last number of years in Singapore has been to try to find ways to tackle these issues, right? I'm not saying that we have found solutions for everything, but I think we have made some important progress in the last decade or so as well. So one of our early strategy about drug access is that, we go to meetings, all of us, hear these exciting, outcomes that are reported in the European meetings, in the American Society of Hematology. In fact, in today's social media world, many of our patients are very savvy. They go online, they may even follow the tweets from ASH and so on. They get excited about all these new treatment. But in truth is that these treatments take a long time to get to Singapore or sometimes our region because there is a process to getting drug approval, getting registration with our health authority, and bringing the drug here, right? And being a small country, sometimes we are not high up in the pecking order, right? People will prioritize the larger markets first before they come to Singapore. And so we decided that one of the good way to get these drugs early to our patients is through clinical trials. And Singapore being a small country, if you go and pitch a trial idea to a company, right, using their effective drugs, they may again not entertain you because you're a small country, right? How many patients can you recruit? Why would this be something that we want to support, versus other countries, right? So we decided to form a partnership in Asia called the Asian Myeloma Network. And this is under the leadership of the International Myeloma Foundation, which is a key global foundation to look after myeloma patients' education, research, to try to improve outcome of myeloma patients. And in this partnership, there are countries and regions like China, Hong Kong, Taiwan, Korea, Japan, Thailand, Singapore, and then more recently, Malaysia is part of this network as well. And so now we are a much more consolidated, a stronger team that can go and pitch interesting trial ideas to pharmaceutical companies. Thankfully, Singapore was asked to take the lead in designing the studies and taking the lead for the clinical trials part of this network. And it has been hard work, but I think our hard work is starting to pay off now because we now have 6 clinical trials to date. And For some of the patients at the General Hospital or at NUH, you may well have participated in some of these trials as well, right? So we call them AMN something because Asian Myeloma Network clinical trial number 1, 2, 3, 4, and so on. And these uses many of the new drugs that have been approved in the last 5 years or so, like pomalidomide, carfilzomib, daratumumab. These drugs are all very expensive when they first become available. Through these trials, the patients get access to these drugs for free if they are participating in the trial, right? And we have 2 of the trials completed, 3 more ongoing. And I think you can see there in terms of numbers, they have benefited 300 or more patients in Singapore as well as the region, right? And so this is an important thing that we have done in the last 5 years or so in trying to bring early access and cheap access to these very impactful treatment to our patients. The other thing in terms of helping to reduce treatment costs for patients, we have also found new ways to do things, right? So one of these things are doing stem cell transplant in the outpatient setting. And then more recently, even in the home setting, right? Clearly, this kind of procedure is not suitable for every single one of the patients that need a transplant because we have to assess carefully whether the patient has got support at home, have got appropriate caregiver, the home environment is appropriately safe. But for those who can, this will actually help to reduce treatment costs as well because they don't need to stay in hospital for so long. The amount of days that they are coming back to the clinic for their blood tests and so on also is reduced. And now we can even do blood tests at home for the patients. And so home transplant will further improve the convenience for the patients. And then the people worry, a lot of people, when we tell them about this option, they get worried because they say, hey, I hear from my friends who have gone stem cell transplant before that, hey, it's a very dangerous procedure, I need to stay in a hospital room for 3 weeks and I have to have reduction in visitors because the risk of infection is very high and so on and so forth. There is some truth to the fact that the infection risk is there, but the beauty about myeloma transplant is that it has a very predictable time course of when the blood counts or the high risk period is and when it could go up. And this period is actually very short, right? And only in leukemia treatment and so on, where the risky period is very long, that the risk of infections and so on is actually really quite high. But we felt that we have to prove in a formal study to people that this is indeed a safe procedure, particularly because we wanted to get MOH to provide some additional subsidy for our patients undergoing this treatment so that they can mobilize some of their MediShield, MediSafe money for outpatient-based treatment. We show in this study, in our first kind of 10 patient experience, and this pretty much have continued, over the years, same kind of outcome, that you can save costs by about 30%. The amount of time that you stay in hospital or engage with your physician is reduced. Of course, some of these patients who do outpatient transplant, they may develop a fever that may require them to go back to the hospital for inpatient treatment like antibiotics. So it's not completely zero, but you can see way less. But the great thing is that clearly the system is working well because the patients who develop complication that we worry about, like neutropenic fever, or even have a death as a result of the transplant procedure, is no different, way less, right? I mean, there is only one treatment-related mortality for inpatient transplant, 0 for the outpatient, right? So this is a safe procedure that saves costs, and that give comfort and additional good quality of life for our patients, because every one of our patients complain about the food in the hospital, the isolation in the hospital, the TV entertainment in the hospital during that long stay that they have to have in the hospital. So the home comfort actually is also an additional benefit. So we have come up with new ways to reduce costs for our patients as well. And then for convenience, we have actually developed a home-based treatment that we can give certain types of treatment through, like bortezomib, which is a subcutaneous injection. We developed some years back this bortezomib at home program in partnership with Janssen. And now I think this program is widely available in Singapore through different format. And this is some data that shows that it saves definitely clinic visit, waiting time, some kind of cost avoidance, particularly for the more older patients where caregiver have to take leave from their work to bring to the patients to the hospital. These can be all prevented because we can do it at home or in a nearby community outpost potentially as well. And so bringing different comforts and convenience and benefits to our patients. And actually, this actually then provide a platform actually now that we have expanded to what we call NSYS on the go, where we can give different types of treatment, including Zometa and so on, in a community-based setting. People can also go there to have their lines flushed and taken care of. They don't have to travel all the way to the hospital if they live far from the hospital. And in the future, where some of these treatment that we currently use, like daratumumab, will be approved for subcutaneous use or other subcutaneous type treatment, we can actually also deliver them in the home or community setting, not just bortezomib alone. And we are also starting to explore even intravenous treatment that is a short infusion that potentially we can do it as well. And so the scope of service is expanding, and certainly this will help to make it even more convenient for our patients. In terms of building the community, we felt that this was important because now there's more and more profile on myeloma. It's an exciting and very fast developing area. There's a lot of information that patients sometimes are not sure about. And also we have patients that actually seek to have other people that they can talk to and share experiences, ideas, learn from each other, right? Because a lot of the tricks that you have identified to help yourself cope at home with certain treatments, sometimes they are not really very medical, right? And these are the components that are very helpful also to share. So that's why we started the Myeloma Forum in 2011. You can see that this was held in a nice setting in a Shangri-La hotel. And we have actually the chairperson of the International Myeloma Foundation, Susie Novis, top left, and Professor Brian Dury, who is leading and helping us push our agenda in the Asian Myeloma Network now, visiting all those years ago. And we have very active patient sharing and support. And many of these patients are still with us today, ratifying this improvement in outcome. And in fact, many of them are on this webinar as well. We have developed a social media platform, again, to help bring people together for sharing. We have done recordings of previous forums and make them available on Facebook and YouTube so that the participants or even others in the public can go and view. I know there was a lot of question about sharing of slides and so on. We will actually ask our speakers, as in the past, whether they're willing to share some of their slides. If they are, we'll make it available through a web link. Subsequently, we'll think of how to do this. And also, there is a recording of this webinar as well. We will actually have to review whether the recording is of good quality. And if they are, we are certainly happy to share the webinar via a link for people in the future as well. But what is great about this is that really it's becoming more like a family, right? And when a family has needs, everyone come together to contribute. And I think in the early days, 2015, so 5 years, that's a fifth year anniversary, one of our patients, Mr. McCulley, actually, if he doesn't mind me mentioning it, anyway, the name McCulley is on the poster as well, decided to get his family together, his actual family, which are multi-talented family with, ballet teacher, rock musician, guitarist, and so on, to put together a show that actually helped to raise funds for myeloma. And then, I think this was in 2014. And then in 2015, again, some of our patients, caregiver, and supporters came together to have a myeloma charity walk and cycle. At that time, graced by Mr. Koh Boon Wan, who's one of the minister, to grace this event and help us raise money. And so I think, as you can see, myeloma treatment wouldn't have made all these progress without research, without clinical trials. And I think it is gratifying to know that our patients, when they can, they want to contribute back to the community, because these donations help us a lot in pushing some of our research agenda and helping other patients sometimes as well that have difficulty in accessing some of these expensive drugs. What does the future hold? I think on one slide, this big hope that we have, because we have made so much progress, but the progress doesn't just stop here. Because in the coming years, we'll have more treatment, immune-based therapies, new targets for treatment that is different from those drugs that we have now that will help. We have better treatment, right? Because these are not just more treatments, right? But they are actually better than even what we have now. The response rates are higher. The side effects profile are in general better. And with that will lead to improved outcomes, longer remissions, higher cure rates. So 30% now, maybe in 5 years, 10 years time, it will go up to 40%, 50%. This is what we are all trying to push hard towards. And we'll have better support for our patient, right? What we mean by that is actually over on my side in NSYS, we are actually developing a cancer patient app, an app on the phone for our cancer patient. And this app will have a series of different functions, which I'll highlight briefly in the next few slides, right? It will have a cancer navigator function where it will help you, remind you on your different schedule and what those schedules are for. You know, is it for chemotherapy? Is it for blood test? Is it for a scan? Is it to see a doctor? Because we all recognize that cancer treatment is very complex, right? And we often miss appointment. We're not sure why we're going somewhere and so on. So this will have a navigator function, and it will provide treatment support. It will explain to you what are your treatment. This is an example for a colorectal cancer, because our initial modules are for other types of cancer, right? But we're developing for different cancers, right? So you have your treatment information, what are the side effects commonly that you may have, and also it will be able to track your lab results and provide graphs of whether things are improving or not. You will have information that you can call up through the app. You see all these different buttons that you can click on. You will actually have these smart informations, and you will get information on what are the kind of supporting services that you can benefit from, like physiotherapy, right? So on here, you can even view videos that is relevant to your condition, like myeloma patients. What are the kind of physiotherapy exercise that you can use? And diet, right? You will be able to have a virtual chat with a dietitian. Because we have a chat bot that is built in. You can ask questions. If I'm on this drug, can I take this? And you can have a conversation actually with the app, like a WhatsApp chat, right? And it will have recipes that will be suitable for you. If you're a transplant patient, what are the kind of recipes that will be good for you? What are the caloric intake that this will be? And this will be available. And medication, right? We will actually have a specific pictures of the different pills that you may be taking, so that when you drop something, and this is a common question, you will know what pill you have dropped, what is it for, and is it important to take? If not, then don't worry about it, right? So these are the information that the patients will be available. We also will have built-in symptoms trackers. Some of these can be linked to your smartwatch or your Fitbit. Some of them you may have to enter yourself, but the app will prompt you. It will then track, your symptoms like fatigue, fever, pain score, number of times that you're vomiting, and so on. And actually, then it will trigger a response from the chatbot, right? It will look at the trend, and it may prompt you to say that, look, you're vomiting a bit too many times. Have you taken your anti-sickness pill today? This pain score doesn't look good. Have you taken your morphine or whatever that you have for pain today? Or when it's a bit too much, they will even prompt you, maybe it's time for you to call the cancer line to check on this. But what we actually hope is that we will monitor this in our system, where we can actually proactively call our patients. Our cancer line can actually call them ahead of time, ahead of the catastrophic event, to ask them how they're doing. Right, so these are the kind of monitoring and even the chatbot and the artificial intelligence that we're building into the app, right? And they can have their own community, just like what we are talking now, because they can join support groups, they can join fitness group, they can join cooking groups, and other things that may be relevant to them, so that it helps them go through the cancer treatment process. It helps improve their wellness. And to be fair, patients spend more time outside of our treatment center and with the doctors than they have with us. And so we want this app to act almost like a virtual health coach to our cancer patients. And actually, the app also have a caregiver module so that the caregiver can know and track what are the patient's appointments and so on. But the caregiver module will have information maybe more relevant to the caregiver, because the caregiver needs to be taken care of as well, because they often have a lot of stress and worries. And so we will have these kind of psychosocial well-being, wellness module that may benefit them, and including, what are the kind of clinical trials that patients may be available, but it will be customized to the different specific disease group. So coming soon in the year 2021, next year, we will have the myeloma module of this app available, initially probably as a beta test for the patients in NSIS, because we want to test out how the flow and everything works before we roll it out broader to the rest of Singapore. So I think with that, last slide already, I think myeloma patients have a lot to look forward to in the future. It has gone from an incurable condition that has very toxic chemotherapy-based treatment with poor quality of life, where there's no variability to treatment. Everyone gets one type of treatment with very limited choices, and the patients are not part of any sort of community, right? To today, our patients are getting longer survival. Myeloma is very much perceived as a chronic disease. The treatment are well tolerated and very effective, leading to better quality of life. In fact, very often, you go on the streets and you don't know the myeloma patients that's just walking next to you. They are almost as good as a normal person, many of them, right? And we now have many treatment options that we can customize to the patient's underlying symptoms and background condition. And we have a community, we have support. And this community is a community of patients, of caregivers, of doctors treating myeloma, of other people doing research in myelomas. And I think this is something that we hope will continue to grow and will continue to benefit our patients going forward. So thank you very much for your attention. And I'm happy to take questions at the end together with other panelists. Thank you very much.
Thank you very much, Professor Chong, for your inspiring and informative sharing. So we'll move on to our next speaker. Dr. Daryl Tan is a consultant hematologist at the Mount Elizabeth Novena Hospital. Dr. Tan will share with you on navigating the complexities of myeloma treatment options and the importance of patient advocacy.
Thank you very much, Sini, and good morning to everyone. It's nice to see old friends and patients in the participant list. As you can see, I'm currently in my clinic in between patients because Saturdays happen to be my myeloma clinic day. Because most of my myeloma patients, they like to continue live working from Monday to Fridays, and Saturdays just coming in for infusion of daratumumab or injections of bortezomib, as if they do not have cancer, attesting to the fact that we've come a long way from the old days where patients get admitted for infusional chemotherapies for multiple myeloma. Right now, myeloma patients indeed lead very normal lives. So as you have heard from the earlier speakers today, myeloma treatment is indeed complicated, but do not be discouraged if you are lost, because many of my medical colleagues have no clue of what myeloma is, and let alone its various treatment options. My task is to try to put everything into perspective and to explain the rationale of why various options are recommended for you, and also highlight as a patient body what you could do to enhance the entire drug access availability process to improve the care of patients with multiple myeloma. So I always like to begin with a reminder of who Sarah Newsbury is. She is the first described patient with multiple myeloma in the year 1844. You can see from this picture that she had multiple fractures. As a result, she had a very contorted look. But this is the old face of multiple myeloma. Currently, you do not see such patients with myeloma patients anymore because the face of myeloma has changed. Not unexpected, because in the old days, what Sarah had for treatment, these were like rhubarb, orange peel, and leeches. But now things have changed dramatically. The World War, with the war, chemotherapy was accidentally discovered. Some of these agents became the mainstay of treatment for chemotherapy, as you have heard earlier: cyclophosphamide, melphalan, adriamycin. At one time, we were giving patients this infusion called BAD, where patients have to come in every few weeks and stay in the hospital for the entire week. Now, these have changed dramatically. And earlier on, you have also heard from Dr. Chen that in order for the body to allow to take in the maximum dose of melphalan, autologous stem cell transplant was developed. And also, we used to be doing a bit of allogeneic stem cell transplant, but largely this is only reserved for very selected patients nowadays because of its toxicities and the availability of many new treatment options that come with way fewer side effects. So at the turn of the century, we figured that instead of killing every dividing cell, cancer cells and normal cells included, why don't we just focus on taking out structures that are vital for the survival of the myeloma cell, as well as target unique proteins on the myeloma cancer cell. This is immunotherapy. And this led to the discovery of bortezomib in 2004, which essentially inhibits a garbage bin in the cell called proteasome. At the meantime, we also realized that to take out the myeloma cell, we have to take care of the environment that condones its existence. So this is what we call immunomodulation. So with drugs like thalidomide and lenalidomide, overnight we suddenly changed myeloma from a terminal disease to a chronic disease. Now, you're all aware that there are new generations of these classes of drugs and also many novel agents as well. So are we any closer to the cure of myeloma? You have heard from the previous speakers. I do agree with them that I wouldn't say we can cure the majority of patients with multiple myeloma. But then again, we are secretly optimistic that we could be nearing that cure, that elusive cure, because of two reasons. One is the ability to measure minimal residual disease. So the prerequisite to cure is actually the ability to measure the most minute amount of cancer cells in your body. The traditional way of measuring cancer cells include measuring your bone marrow plasma cells, your M proteins, or your free light chains. Now with technology like next generation flow cytometry and next generation sequencing, we're able to really measure 1 out of a million cells in the bone marrow, 1 out of a million myeloma cells in the bone marrow, and really measure the bottom of the barrel. And we need to get rid of these last bit of disease before a cure can be attained. And the second reason is the advent of immunotherapy in multiple myeloma. Building on what my previous colleagues have mentioned, we are very excited recently because we have identified 3 targets or antigens on the myeloma cells that we can develop immunotherapy against the myeloma cell. CD38, of course, everybody knows daratumumab, and incidentally this year, HSA has approved the use of daratumumab in the frontline setting for patients who are transplant eligible and transplant ineligible. There's an agent called elotuzumab, which targets SLAMF7, but however, this drug is not brought in Singapore, partly because of a commercial reason. The market is not big enough to bring this drug in. And everyone is excited that we can target BCMA. You've heard earlier on from Yunxin the use of CAR-T therapy, which is going to come into Singapore very, very soon. But the downside of CAR-T is the cost. It probably will cost about between $250,000 to $500,000, which is an enormous amount for any patient. And I'm glad to also announce that very recently, in fact, about a couple of months ago, the FDA in America has approved this drug called belantamab mafodotin, which is actually a smart bomb. So the antibody identifies BCMA, and smart bomb is then unleashed into the myeloma cell. These compounds, though not available in Singapore, can be actually brought into Singapore with special arrangements. So let us just study how a single drug, immunotherapy drug, daratumumab, has impacted on survival of patients with multiple myeloma. The best way to study effect of these new drugs is actually to glean from the experience of patients who are transplant ineligible. Now, you probably are familiar by now that this is the general algorithm of treating multiple myeloma. We always like to segregate patients into whether they are transplant eligible. These are usually patients who are younger, less than 65 to 70 years of age, versus those who are transplant ineligible, patients who tend to be older and may not be able to undergo stem cell transplant. The difference is consolidation or autologous stem cell transplantation. In the older days, if you do not go for a stem cell transplant, you cannot tweak or defy the natural history of multiple myeloma, and survival was a very dismal 2 to 3 years. Now, currently with the latest statistics, after undergoing autologous stem cell transplant, the remission duration is probably about 4 to 5 years before the first relapse happens. Now, if we were to glean from the experience of patients who are transplant ineligible, I've laid out for you the evolution of standards of care that we use for patients who are transplant eligible, patients who are not going for stem cell transplants. We started with melphalan, prednisolone, and then Velcade came along. We could do Revlimid, and we could combine Velcade with Revlimid, and in the year 2020, we could add daratumumab to Velcade, to Revlimid, or to both. So these are regimens that we have over the years. Now, if you were to look at the success rate or response rates, as Viju has rightly pointed out, with the addition of daratumumab, we're now getting closer to almost 100% response with the use of these very powerful agents in the frontline setting. In terms of the duration of remission, when we used to use melphalan, prednisolone, we were just keeping patients in remission for about a year. With these new drugs, then we're pushing this remission duration to 2 years, 3 years. And with VRD, which is a very common regimen nowadays, used almost somewhere between 3 to 4 years. Now, with adding daratumumab, actually the data is still young, but the projected remission duration is easily probably in excess of 4 to 5 years. And this is actually the duration you could expect with the use of autologous stem cell transplant. So this goes to show how powerful these immunotherapeutic approaches could be in the frontline setting. And the excitement doesn't end there, because by adding everything upfront, for instance, daratumumab with Velcade and with Revlimid, we could actually expect half of these patients to attain MRD negativity. And this, again, is the prerequisite to very long remission durations and even cure of multiple myeloma. So, if I have a crystal ball, I could probably foresee that in the very, very near future, we'll probably break down this discrimination against patients who are transplant ineligible, and every patient will be treated with the same algorithm, same treatment protocol, and older patients will do just as well as patients who are younger. But at this point in time, transplant, I must emphasize, is still a very important, cost-effective way for treating multiple myeloma, especially if patients are still fit, or if they have got high-risk disease with bad mutations in the bone marrow. Now, so if these upfront kitchen sink approach, or the best agents upfront, if it is so effective, why don't we give everyone daratumumab with Velcade and with lenalidomide? The simple reason is because these are terribly or insanely expensive. If you look at the cost of Dara VRD in a month, it can probably easily set you back by $20,000 to $30,000 a month. The sad truth is that the healthcare for cancer in the Singapore context is still largely based on a self-paying market. If you have a good shield plan, integrated shield plan with a rider, then yes, this may not be an issue. But for many others, without these riders, to a certain extent, money is still coming out of your pocket from deduction in MediSave. It's still ultimately your life savings. Now, if we have a chance to perhaps offset the cost by using generics for these drugs that are already established, like lenalidomide or bortezomib, then perhaps we will certainly defray the cost of these very effective regimens up front and allow many more patients to be able to get these regimens very effective regimens early on in the life with multiple myeloma. So this is looking at American statistics. Over the years, indeed, the survival of myeloma has improved tremendously, and now the survival is actually inching closer and closer to the survival of the healthy population. But there is a price to pay, because to get this curve right up here with improved survival, you're looking at expensive regimens like VRD, KRD. This is American statistics, but Singapore dollars, in terms of Singapore costs, it wouldn't be too far off. Almost $250,000 a year just to treat multiple myeloma, unless you have a very comprehensive insurance coverage. Otherwise, you have to be crazy rich to be able to afford such expensive regimens for treatment of multiple myeloma. And the problem doesn't just stagnate there. I mean, the cost doesn't just stagnate there. If you look at the average cost of treating myeloma per patient per month in America, from the year 2000, it was probably $3,000. 2014 was $14,000, and right now, 2020, with daratumumab upfront, it would easily be in excess of $20,000 per month in treating patients with multiple myeloma. So why are myeloma drugs so insanely expensive? Largely, it's got to do with recuperation from the high research and development costs borne by the pharmaceuticals. And in America, under Obamacare, Medicare could not negotiate the drug prices, and reimbursement in America encouraged more expensive options. There's this evergreening of patents of these proprietary drugs and lack of generics, such that the pharmaceuticals do maintain a certain monopoly over these very essential drugs for multiple myeloma. As a result, the high cost of these treatments gets translated to the rest of the world, and that's why you're paying these exorbitant prices for myeloma drugs nowadays. And if you look at the trend of FDA approvals for new drugs used for treating cancer, you see that with every sequential year, these drugs tend to get more and more expensive, such that right now, on the average, every new drug that's approved by the US FDA would average about $20,000 to $30,000 per cycle. The problem is further compounded by the fact that when a patient relapses, he or she has to be treated with the next generation novel drugs, or he or she has to be treated with drugs from another class. So overall, in the lifetime of a patient with multiple myeloma, he or she would have seen many of these drugs that I've shown on this table here. And this is the best way to ensure long survivals for patients with multiple myeloma. But the rule of the thumb is that the newer generation drug will always be more expensive than the previous generation, and newer classes of drugs will always be more expensive. As I've highlighted to you earlier on, CAR-T therapy will probably cost anywhere between $250,000 to $500,000. Viju has pointed out rightly that clinical trial would be a way to gain early access to these drugs that have not been approved by the healthcare authorities. And also, some of these trials will dish out free drugs for participants. But on the average, from bench research to bedside commercial use, it takes about 5-10 years. But recently, we have seen that with COVID vaccination trials, actually, this process can perhaps be shortened. 1 to 2 years is very, very impressive with COVID vaccination. But then again, multiple myeloma is not a public health crisis. Well, we can always lobby to get these approval processes expedited, but it will never be anywhere near the 1-2 years that you see for COVID vaccinations. Now, to put everything into perspective, a patient, throughout the life of a patient with multiple myeloma, it would be characterized by recurrent remissions and relapses. This is remission 1, remission 2, 3, 4, and 5. Ultimately, the disease becomes very resistant and stubborn, and becomes more and more difficult to treat the disease. Now, many patients of mine would always voice that they will want to conserve the resources until the disease becomes very aggressive towards the end. But the trend is that we tend to spend more money or resources treating late relapses because these drugs are already most expensive. They're always the latest drugs. But yet, they only accord a shorter remission duration. Now, those of you who are in the commercial world or who has been investing during this COVID era, you know that from medical or scientific standpoint, actually, the return on investment is actually highest when you invest on the first and second line treatment, because this is the time that you experience the longest disease-free remission, and this is the time that you have the best quality of life. So for patients who are not getting daratumumab in the frontline setting, I would want to make sure that when they first relapse, they get a daratumumab or other immunotherapeutic approaches, because we want to make sure that this first and second remission becomes longer and longer. Similarly, that's the reason why we always advocate stem cell transplant for patients who are transplant ineligible, especially if they do not have access to these very novel drugs, because their remission one will be could be the longest if they go for stem cell transplantation. Now, the treatment of multiple myeloma used to be very simple when we only had Marfalan and prednisolone. In those days, anyone can treat multiple myeloma, but now we have to look at the resources the patient has, insurance regimens, insurance coverage, look at the diagnostics, the genes, the mutations of the myeloma cells, make a proper informed decision with the patient, and look at all the treatment options that we have, including transplant, novel drugs, clinical trials, and very soon CAR T therapy, to choose the best option for patients that will give the best outcomes. So a myeloma physician right now has got a terrible task, because we want to be to have knowledge of all these different lobangs. So this is the best way to treat myeloma, actually. That's why, as Viju has rightly pointed out, in this community, we share resources, and I do get to know what are the clinical trials that have been run in NUH and SGH, so that patients who will benefit from these trials or these drugs, they automatically be referred to these clinical trials. Now, the hard truths about multiple myeloma care. Well, the good news is that I hope I have shown you beyond reasonable doubt that patients are living longer and longer. This is quite akin to a chronic disease right now, no longer a terminal cancer for majority of patients. But the hard truth is that myeloma is actually one of the most expensive cancers to treat. The key to improve the survival outcomes is the sustained access to novel therapeutics. So you have to be on these novel drugs on a very protracted course. Escalation of costs involved in myeloma care may not be sustainable by many healthcare systems. So simply, the healthcare system in Singapore, I don't think it can support daratumumab, Velcade, Revlimid indefinitely for most of the patients in Singapore. So engaging various stakeholders is key to finding solutions for affordability and access. So what are the stakeholders in this case for multiple myeloma care? They are you, me, the physician, the patients, the healthcare authority, the industry, or the pharmaceuticals that are producing these very effective multiple myeloma drugs. What can Ministry of Health do? Well, they could negotiate for prices for these myeloma drugs to be lower, improve formulary control in hospitals, allow importation for personal use. For instance, a patient who is now who has failed all drugs available for multiple myeloma is not eligible to join a clinical trial. What HSA is helping actually is, for some of these cases, HSA has been very forthcoming in approving importation of other drugs that are not commercially available in Singapore, like for instance, alotuzumab or belantamab, the new drug that has been approved in America. And the healthcare authority can also facilitate easy entry of generics and biosimilars, because this will really help defray the cost when we combine these very effective drugs together. The industry and the pharmaceuticals will have a role to play as well. We always back them to lower down the costs of these drugs. And also, to a certain extent, we would like to see transparency on research and development. And for physicians, the onus is on us to actually improve treatment guidelines. We know that these drugs are effective, but they're very pricey. So as the Asia Myeloma Group, we set resource guidelines so that these expensive drugs will not be abused, but rather to improve or optimize survival outcomes. We make sure that doctors follow a certain set of resource stratified guidelines. Very importantly, we need to educate patients on what myeloma is and the various treatment options. Sometimes half the battle is won when the patient is very well informed about the disease. How about patients and caregivers? What can you do to help reduce the price of drugs and gain or avail allow easy drug access for patients with multiple myeloma? I need to stress the importance of patient care organization and advocacy. So I always like to illustrate with this case of a patient from China. So this is actually a real life case of a man called Lu Yong. This story has actually been made into a movie, which was a blockbuster in China 2 years ago called Dying to Survive. So this guy, he was a drugstore owner, but he was struck with a disease called chronic myeloid leukemia. So this is a disease, kind of blood cancer, where if you do not go on a drug called imatinib, survival is about 4 years. But if you are on this drug, your survival is the same. Your life expectancy is the same as anyone who is healthy. So because at that time in China, there was they did not allow these proprietary drugs. So as a drug store owner, he imported generics from India. And in the process, he imported the drug imatinib for almost 1,000 other fellow patients with CML in China. But when the authority got news that he was importing these generic drugs illegally, they wanted to prosecute him. But to his rescue, these 1,000 other patients rallied behind him. And as a result, the authority dropped charges against him. But because of this case, the central China government actually started to allow easier access to generics and also easier importation of these proprietary drugs from America. So from this experience, you can more or less tell that the patient's voice sometimes can be the strongest, right? So as a patient support group, if your voice is heard, sometimes the healthcare authority could barge, sometimes the industry or the pharmaceuticals could barge and give you easier drug access. Now, on the one hand, we need to obey or we need to respect patents and intellectual property. Most of these drugs were developed in America. On the other hand, myeloma lives do matter. So we need to choose a middle ground where we still allow these drug companies in America worldwide to develop these very innovative drugs to cure or to treat patients with multiple myeloma. And we must always play a part in helping to avail these drugs so that the outcomes of patients with myeloma will be tremendously improved. So the role of the physician, in essence, like this forum today, is to empower patients with the right knowledge so that once the patient body is empowered, they're able to, you could be a formidable force in engaging the stakeholders, the industry, the healthcare authorities to lobby for various agendas, which I subtly identified earlier on in my talk: easy access to generics, reduce the out-of-pocket co-pays for expensive CAR-T treatments, more drug trials, lower drug prices, and faster drug approvals. So we originally intended to run this first Asian myeloma patient support seminar in Singapore this year, but because of COVID, we have to postpone this meeting to next year. So this meeting is going to be held in Hong Kong. Right now, we still have a travel bubble. I'm not sure what's going to happen in a year's time. This meeting is going to be held in Hong Kong, where the various Asian myeloma support group members or participants will come together, share best practices. So do log this down if you're interested, because this is your opportunity to find out how other patient support groups in the region are doing, how they squeeze the government or the pharmaceuticals for best prices of these drugs so that everyone else can enjoy the benefits. So to end, I just want to share with you a quote from a social worker: with access to treatment, a patient is able to live now. With access to support and education, the patient is able to live well. And with capability building, a patient is able to live for the future. Thank you very much for your kind attention.
Thank you very much, Dr. Tan. Now, last but not least, let us invite Mr. Peter Gui, a myeloma patient, to share with us his journey on mindfulness.
Good morning to everyone. My sharing this morning will be very short as compared to other speakers before me. It will be my sharing on mindfulness, and it will be my experience and my benefit that I've gained from this practice. What is mindfulness? In short, it's a step of stepping out of your mindless mode to be in the present and moment by moment daily. I hope after this sharing, it will translate to you exploring yourself and its benefit. Anyway, it started off from books I read from the library. There are several books that you can find, and there are a few translated from Japanese too. And recently, there's a new book on nature, health, happiness, a joint effort by NUS Mind Science Center and NParks. After attending a course on this mindful-based cognitive therapy, in short, MBCT, it deepens my knowledge and understanding of mindfulness. I call it a drug-free therapy. Okay, here you find that, from this experience, I found out that for me, the 3 minutes deep breathing exercise was the best for me. Of course, there are other techniques and regimen that you probably that I've learned, but this 3-minute deep breathing exercise was the best for me. It's a 3-second inhaling and 6 seconds exhaling. It's recommended that you sit while doing this exercise, but I do it anytime, anywhere, and I do it standing, walking, and every time I feel anxious and down, I will do this 3 minutes breathing exercise. I find this to be very relaxing, and it helps me a lot in my anxiety and in my moments of being down. And I hope that by sharing this, those people out there who has been a patient and be able to explore this exercise and this experience. Okay, one of those experience I had was also mindful walking in a park, and I do this practically 4 times a week, and it's like spending time in the park is so enriching. Of course, if those of us who are at home, you can also do it in your home, okay? And we're walking the park, we are often engaging with the beautiful patterns on the leaf, flowers, branches, and trunk of trees as I walk through these parks. And I could also be familiar with the sound of the birds, squirrel, and the whispering wind too. So all this evokes a sense of awe and gratitude for me as I take my morning walk. And I enjoy the peace and calm that come along after my walk. And this has been a great help to me because from time to time, I will feel a little bit, there's a lot of anxiety, and I always look forward for this walk in the morning. My outcome is my blood pressure is good, is under control. I had good sleep here, good long sleep and quality sleep. And it has helped to reduce my stress and anxiety level. I'm more able to accept and let it go. I fret lesser, So overall, my physical, emotional, and mental health is good. I'm much stronger in spirit, soul, and body too. So before I end, I'd like to thank you for listening, and for those of us who are myeloma patient and caregivers, stay positive, stay hopeful, and be an overcomer. Thank you for listening to me. Thank you.
Thank you very much, Mr. Gui, for sharing with us. Now, I'm going to open the Q&A section. If anyone have any questions to any of the speakers, please feel free to type out your questions. I'll start with the first question. So now with this current pandemic situation, I think this question is very important and of great interest to everyone. So with the upcoming COVID vaccines, what is your thoughts of will like the compromised immune system of the myeloma patient respond positively? And what's your recommendation for the myeloma patients in different disease stages, like for instance for active treatment, maintenance, or patient who is stable of treatment?
Maybe I'll take Sini. I think you can direct the question to different people as well. Or else we'll all keep silent, right? So okay. So in the on the vaccine, right? I think Dr. Lee did type in the answer on the online question as well, and he gave a very comprehensive talk about the different types of vaccine. Right. So in general, I think for vaccine, we don't suggest patients have any kind of live vaccine in myeloma, but other types of vaccine, actually, we expect that they will be effective, right? So if this is a question that myeloma patients with the immunosuppression, the treatment, will vaccine be effective? The answer is yes, because after the transplant, we will actually revaccinate all our patients, and we expect that the vaccination will work, right? So in the specific case of the COVID, there are many different vaccines that are being developed as well, and so we need to look at these factors: what kind of vaccines they are, and whether they are live. I don't think any one of them are, and if they are not, then just like the flu vaccine and other vaccine, we would expect that they will help myeloma patients as well. I mean, that's my thoughts. I don't know whether others have any other comments on this as well, like Mauli and Daryl.
Yeah, so I agree with you. When the patients are on active treatment, when they're on high dose steroids, vaccination may not be effective because you need to mount an immune response to produce antibodies or resistance or immunity when you're given vaccination. But usually after the patient has come off induction, come off transplant, usually we routinely give it 3 months after transplant. That's when your immunity has recovered, and that's when the vaccinations would be more will work better after the intensive phase of treatment.
And, okay, please, Dr. Mauli.
Yeah, thank you. Sorry, I just want to mention, I don't think we can comfortably answer this particular question with regards to COVID vaccine one way or another at the present time, because every day there are discoveries, even into the immune response of the COVID. Initially, there was a lot of thought on the usefulness of antibodies in countering the COVID and COVID-related complications, but now the pendulum is swinging fully towards the other side of immune response. So I think we'll have to wait and see when the vaccines come on, what type of vaccines they are, and how and what type of immune system response is particularly going to be useful. So I think we'll have to watch this space.
Okay, thank you very much, Dr. Mauli. Does anyone have anything to add, Dr. Lee?
I would tend to agree with Dr. Mauli that we need to watch. There are quite a variety of vaccines coming out. And I think as much as possible, we like to vaccinate our patients, but how much benefit they derive, we still do not know. And so at the end, it's still about weighing the benefit versus any possible, adverse event, and also giving a false belief that it gives protection to the patient. Yeah.
Thank you, Dr. Lee. Dr. Chen, do you have anything to add?
No, I think everybody covered quite thoroughly.
Yeah, okay, thank you very much. Okay, we'll move on to the next question. So there's a question of what is the cause of myeloma relapse?
So in the pathogenesis, which means like the development of myeloma per se, the plasma cells are cells which produces antibodies. So because we need a huge repertoire, sometimes during the development, a lot of genetic mutations can occur. With treatment, we try and bring them down to very low levels, but at times we cannot get rid of all these abnormal cells. And these remaining cells, what we call residual disease, are the source of myeloma relapsing. So they can gain additional mutation, they can evolve clinically and give rise to different clones of myeloma cells. And usually it's because of remaining residual disease that predisposes a patient to relapse, and the disease can gain new mutations and give rise to more resistant clones or more difficult clones that are difficult to treat with subsequent treatment therapies.
Thank you, Dr. Chen. Dr. Mauli, maybe you want to add?
Not much to add, actually. I mean, there are many reasons why myeloma relapses. The bottom line, I think, is in most patients, by research, it has been found that on an average, patients have, even though we call them as one group of myeloma, there are many different types of cancer myeloma cells within them. When we treat with one combination treatment of 2, 3, or even 4 drugs, it tends to target a vast majority of the myeloma cells within them. Whereas there are going to be still a small population of myeloma cells that potentially could be resistant to the combination of drug treatments that they are going to be having. Hence, these cells kind of go into a hiding mode for a temporary period of time, which can vary from few months to few years in a certain case. And when the drugs have been taken away, or even when they continue, they find a way or mechanism to get over these group of drugs because they are inherently not suppressed by the group of drugs that this patient is receiving. And hence, that's the reason why myeloma relapses in most of the situations.
Thank you very much, Dr. Mauli. Okay. If there's nothing else to add for this topic, I'll move on to the next question. Okay. This is thank you, Professor Chong, for a great presentation and all your great work. The app looks amazing. Do you have a link to be able to support the myeloma support group that you spoke about? Like maybe the question about what are the available support group for multiple myeloma, maybe in Singapore.
Yeah, so this is, I saw that question online, but our myeloma support platform is actually, I mean, this is not the app, but the general myeloma support network is actually on Facebook. I need to go back to my coordinator to see whether we can share this, the Facebook page, because currently it says private, so I don't know what it means, whether it's only for the current members or it's more for the public. So I need to check that. But Mike, I think I will be seeing you sometime soon. You are one of my patients, so I will let you know the information. But we will also make sure after this event, if because I think there are some interest from others who want to join the support group Facebook page, that we will see whether we can share it with the public or not, because we have your the email list when you sign up for this meeting. So that's the one. In terms of the app, it's still in development. As I answered one of the other question, is that when it's ready sometime next year, we have to deploy it in probably our own hospital first, because we need a period of beta testing so that we put the app in someone's hand and let them use it, and get feedback to improve it before we will roll it out. First of all, probably Singapore-wide, and then we'll look at how to roll it out overseas as well. Currently, the app has some advanced function which actually may entail some linkage to the electronic medical record. So we're also designing it to see whether we can actually still have a very useful functional app without that element, because that will make it easier for us to use it for individual patients overseas and so on that may not have a link to the electronic medical record. So you will hear more about it in the coming years. But it's our aim to make it available broadly. So, it may just take some longer time to reach the different sectors.
Thank you, Professor Chung. Next, we'll move on to the next question. How do you encourage a newly diagnosed myeloma patient towards positive vibes? Maybe Mr. Gui, you can share with us your experience.
To me, is to stay positive, stay hopeful. And I think from hearing from the doctors who have spoken this morning, I think there are a lot of hope out there. There's like Professor Cheng has mentioned, the progress that has made over the years, I think is tremendous. And I think I'm very hopeful that one day we'll find something closer to cure rather than just a full cure, and that's my hope. Thank you.
Thank you, Mr. Gui. It's very important to be hopeful in this journey.
Yes.
Okay, we're going on to the next question. Are the main takeaways, like for example, the outcomes are better, therapies are improving, but still expensive for myeloma, is similarly applicable to amyloidosis patients as well?
Yeah, so maybe I'll start and then the rest can chime in as well. Yes, the answer is yes. All these, because the treatment of AL amyloidosis, many of the drugs are very similar to, in fact, they're all the same drugs to myeloma. So the kind of improvement in terms of the ability to get a good response, rapid response, prolong the response is exactly the same. But there's it's same in the sense that the direction is the same. The amount of improvement and so on may be a bit different because the two conditions have slightly different outcomes and so on. But I think the key difference is this. Amyloidosis patients, because of the nature of the disease where different organs may be affected by the amyloidosis, the likelihood of certain side effects or complication may be higher. So, the complication from a transplant may be a bit higher because of the fluid and so on that they will be given during the process. And if someone have a heart problem affected by amyloidosis, the ability to tolerate that may be a bit less. So we may need to make tweaks and adjustments to minimize the side effects. So they cannot be just given exactly the same and then you think that it will all be exactly the same. So this actually have to be something that we have to be mindful of. And then same thing as for myeloma, there are still groups of patients with amyloid that actually have very bad outcome. What I didn't stress a lot on is that although we say that 30% may be having a long remission, and this number is going up, I didn't mention that there is still about 10, 15, 20% of patients that have very, very short outcomes. And so we're increasingly focusing more our attention on how to help and understand those group of patients, right? So same thing for amyloid, there will still be a group of patients that current treatment may not have improved the outcomes of these patients by a lot, and those will remain to be a challenge for the coming years and something that we have to do better for. But back to the question is yes, in general, the direction for amyloid is the same as myeloma. The improvement are all heading in the same direction. Yeah, don't know whether Daryl, Yunsin, and about his other comments.
Okay, so just to add, this year we also have seen data coming from Europe that immunotherapy plays a very important role in amyloidosis as well. So to date, whatever works for myeloma seems to be working very well for patients with amyloidosis. So this year we've heard that daratumumab patients with amyloidosis, when they're treated with daratumumab, they have significant improvement in survival outcomes. That is very encouraging. Previously, we already know that bortezomib is a very important drug for amyloidosis. Now, the thing is that previously many of these patients succumb to the disease because the heart fails or the kidney is not good. They go into renal failure. But because we are able to control the source of the amyloid, now these patients are living longer. And in my clinical practice, I'm actually pleasantly surprised that actually some of these patients, just because of these drugs, they're living longer. Their heart starts to improve tremendously. The kidneys start to improve as well. So there is actually a possibility of recovery of the functions of the organ. So overall, things are looking brighter and brighter. And with amyloidosis, multiple myeloma, I think the outcomes eventually will just get better and better.
Okay, thank you very much, Dr. Tan. We move on to the next question. So this question is related to the previous question about relapse. So the question is, what are some of the ways to prolong the possibility of relapse?
I'll take that. So I think in myeloma treatment, like we mentioned, it's very important to look at the whole big picture, but we need cumulative blocks of different treatments in addition to each one, like induction, stem cell transplant, consolidation, maintenance. So when we bring the patient down to very low level disease, now it has been shown that maintenance treatment, whereby we give a single drug or one or two very tolerable drugs, in the long run, it can prolong remission and prevent relapses in that sense. Also, I think more and more so, we are looking at more personalized therapies. There are different clinical trials which look at certain risk factors and whether or not using certain drugs have added benefits to this patient. For example, the high-risk patients, whether or not using different kinds of agents or quadruplet therapy can keep them in deeper forms of remission, such as the use of 4 drugs even right at the onset. So I think in myeloma treatment, the first treatment is still the most important, like what Daryl has said. And in addition to that, to try and prolong remissions, the addition of transplant and consolidation maintenance is all important. Sini, you are muted.
Thank you very much, Dr. Chen. So we move on to the next question. How can myeloma patient cope with daily activities? Is there any activities to avoid? Like for instance, of course, high impact activities should be avoided. What other things? Anything in particular that we should take note of?
Okay, for me, I have to be mindful that my bones are no longer the same as before. So I don't do strenuous exercise, but I do do some stationary exercise to strengthen my back, my feet, and my body. So I do that on a regular basis, but I don't go for numbers. Means I don't want to do it with a certain time and effort. I just feel that I do it. If I cannot, then I'll avoid doing the exercise. Other than that, I live a normal life. I go about in what I do best, and I think and to be mindful and careful, especially during this COVID-19 days, to avoid crowd and to be aware of where you are going. That's my advice.
Thank you, Mr. Gui. Is there anyone that would like to add anything? If not, we would like to. We can end the session. In the interest of time, there are a number of questions that have been answered in the Q&A box that we can have a look. So, ladies and gentlemen, we have come to the end of the 10th National Myeloma Forum webinar. Thank you for your participation and support. A big thank you goes to our speakers, partners, and our sponsors, Amgen Biotechnology Singapore and Takeda Pharmaceuticals Asia Pacific for making this event possible. Here is a gentle reminder to kindly complete the feedback form to help us better improve our future events. It will be auto-directed to the survey page once you leave this webinar. We hope you enjoyed today's informative webinar and have a great weekend ahead, everyone. Thank you.